It's about time we've had Dr. Shane Speights again on Let's Talk Jonesboro. So we have him today to update us on all the latest things. A lot of us feel like the COVID situation is past, and we're not here to scare anyone, but there's a little more to the story. And I want to know from Dr. Speights to just give us a little general overview of Jonesboro and Northeast Arkansas. What's our status, trends, and then the nation at large. Doctor, thank you for joining us.
Thank you, Bill. I appreciate you having me, and always excited to talk to you and talk to the viewers and listeners of the Jonesboro and the Northeast Arkansas area, and give an update on where we are. There's certainly, we've seen a significant downward trend in cases, which is amazing, which is awesome. I think everybody's happy to see that, starting to see that glimmer of hope in terms of the return to normalcy. I think that everybody's been wanting for a long time. When we look nationally, we continue to see, or we have for a while seen, a downward trend. We've now plateaued. So in the United States, it's kind of plateaued off. Now, remember, when we talk about national numbers, that's a combination of numbers from all over the states. And so what I mean by that is if you have one state that has high numbers going up and one state has numbers going down, that kind of plateaus the overall number in the nation. So we do have states, specifically in the North and the Northeast, that actually have seen an increase in cases. Michigan is one of them for sure that has seen a big spike in cases, but it's quite a few states there in the North and Northeast. Some in the upper Midwest have seen an increase in cases as well. And there's different theories as to why that's going on. We know that there's a variant. The UK variant has taken over and is the predominant strain that we're seeing here in the United States. We know that it's more virulent or more transmissible, which means that it can infect people more rapidly. So that means that maybe if you were passing that person in the grocery store, or you were with that person for a short time, and maybe it wasn't enough to get you infected previously, now you're more likely to get infected with this strain. That's just part of the properties of the UK variant. We also know that in those northern states, it's been colder for a while, and so more people have been inside. Here in the South, we've enjoyed the warmer weather. We're able to get out and be outside. We know that the transmission of the virus is much lower, much lower outside. And so that helps us here in the South. And obviously in the rural areas of the state where there are less people, there is less transmission. And so that's another thing that kind of bodes in our favor as well. When we talk about here in the Jonesboro area, here in Northeast Arkansas, like Craighead County itself's averaging about 10 cases a day or so. That's not a lot. One of the things you got to be careful of, and it's kind of one of those things where the devil's in the details, we're not doing a lot of testing. And so because we're not doing a lot of testing, we're not seeing a lot of cases. It doesn't mean that the cases aren't there. It just means we're not identifying them. So I want to caution people on that. Don't get too relaxed in watching those numbers. Now, if we were still having people getting tested at the same level we were, back in November and December, and we were only averaging 10 cases, I would feel great about that. I'd say, look, we're on the home stretch for sure. But because we're not really testing for it and looking for it, we're not picking up on the cases that are out there. So I think that's something that the viewers need to be aware of.
Are we not testing because people aren't coming in for tests?
Yeah, that's pretty much what it is. Back in the fall and even the summer, when this was still fairly a new phenomenon, people would have a runny nose or a cough and they would think, oh, this could be COVID. I might want to go get tested. And so sometimes it was COVID and sometimes it wasn't, but it gave us a good idea of how much COVID was circulated in the area. Now people get a cough or runny nose, they blame it on their allergies, or they just think, it's just a little cold. And some of them probably don't want to go get tested for it. They don't really want to know. And so because of that, we're not really picking up on people that have COVID that may have mild symptoms. The ones now that we're seeing are the ones that end up in the emergency room or end up being hospitalized or at the urgent care setting. Those are the ones who really go in that are, look, I'm sick enough to go in and be seen. Those are the cases. So we're not picking up on all the other cases that are out in the community.
I think there's a complacency that comes with the normalization of our way of life. But you're saying there are still people in the hospital with COVID. There are potentially people dying with COVID in Jonesboro and Craighead County.
Oh, we know there are. But I want to be clear. The numbers are nowhere near where we were over the winter break. We saw our peak here in Jonesboro, Northeast Arkansas, even for the state and the country. Our peak was the November, December, January timeframe. It was the Thanksgiving, Christmas, New Year's timeframe, which is what we thought would happen, was that people would gather, spread the virus, and then we would see that. And that's exactly what happened. We're nowhere near that. And so most of the hospitals, I'd say almost all the hospitals in our region, have actually reduced down or closed a lot of their COVID wings because the numbers aren't anywhere near where they were at that time. So it's one of those things, it's kind of relative. We had lots and lots of COVID hospitalizations and deaths several months ago. We still have some of those, but not near what we were seeing several months back.
What do you see, Doug? And I know you don't have a magic wand or a crystal ball, but you've got a better one than most people do around here when it comes to this. Do you see a possibility or a likelihood even that a new strain shows up and wreaks havoc in Northeast Arkansas?
So let's talk about that, Bill. I'm glad you mentioned that. So obviously I do kind of have probably a little more than the average person in terms of being involved in meetings, statewide meetings, and meetings at even at the national level. And so I can share some of that information with your viewers now. We know that, for example, of the variants that we're picking up now, about half of those are UK variants, but about half of them are the California variant. And that's a domestic variant that we don't know a lot about. We have picked up the Brazilian variant here in the state, and we've got several individuals that are infected with that. Again, because we're not testing a lot, we don't know to what level it's widespread. Some of this data is a month old. The virus spreads quickly, so we've probably got a lot more of that than we even realize. And we can expect to see more of that. Luckily, right now, we feel good about our vaccines. We feel good about the Pfizer and the Moderna vaccine. And even, though there was a controversy over the Johnson & Johnson, we feel good about its efficacy against the variants as well. We feel comfortable with that. The problem is the vaccination numbers. And we talk about the vaccination numbers here in the state as well as in Northeast Arkansas. Here in the state, we're approaching almost 30% of the population is fully vaccinated. That sounds good, but the problem is compared to other states in the country, we're toward the bottom. So we're actually toward the bottom of the list in terms of vaccination numbers. There are many more states that have a much higher vaccination rate, 40 and 50% of their population has been vaccinated, and they continue to see demand for the vaccine. So there's still lines of people that are standing out there to get the vaccine. We're not really seeing that much here in Arkansas. People have asked me, does that surprise you, Dr. Speights? And I'll say, well, it really doesn't surprise me. I think it's unfortunate. I'm a little disheartened by it, but it doesn't really surprise me. When I look back and fold back the pages and say, hey, how many people would get their flu vaccine each year? Historically, we don't do that well here either, specifically in Northeast Arkansas, but along the Mississippi River and the Mississippi Delta, vaccination rates are lower than even for the rest of the state of Arkansas. And so that's disheartening. I think we've got some work to do on education in terms of vaccine safety and how effective they are, and that they do prevent disease, and that they've saved millions of lives each year, and that really it's one of the things that it pulled us into the next basically generation of medicine in terms of technology. And I think that's a bigger conversation, but our vaccines are safe and effective, and they make a difference in people's lives every day. And I think that sometimes when you don't see these kinds of infectious diseases, when people don't see measles, mumps, when people don't see polio, they forget about how devastating it can be. But our vaccines have made us safer.
Do you understand what motivates the movement of fear of the vaccine?
I do at some level. Now, it's obviously I have bias, and I readily recognize that. I take for granted sometimes that I grew up in a family. My mom's a school teacher. My wife works in the school system. My father-in-law, taught microbiology. Obviously going to medical school. Before medical school, I had to take all these science classes. So, I take a lot of that for granted in my understanding of how biology works and how, molecularly and from a biochemical standpoint, all of that works, and our physiology, how our immune system works. I think sometimes I forget all of that, because for me, it's like, well, yeah, why wouldn't I get a vaccine? I'd be honest with you. I think even my kids probably take that for granted because they hear about it from me around the dinner table.
Right.
But I do understand, because I'll be honest with you. I have family members that don't want to take the vaccine. I really do. And so, and trying to drill down, and there's a lot of layers to that in terms of the vaccine hesitancy that we're seeing. Some of it is just not really understanding the science behind it. Some of it's political. I hate to say that. There's some politics, and I always hate when you're bringing politics into, science and medicine. I think that really muddies the water. I think misinformation spreads faster than good information on social media. I think that's unfortunate. I think, there was just yesterday or the day before yesterday, there was an article and it was a typo. They had to go back and quickly address it. But there was a study out of, I think, Israel that said something like, people that got the vaccine, 5 million people that got the vaccine had some sort of heart damage. Well, that wasn't true at all. That was a completely a mistype. It said out of the 5 million, 56 had this, and they were in this age group, and they just decided that there was no relationship at all because these were the young individual athletes that had this anyway, and which is what we've seen in quite a few of our vaccines. But that little typo, that little mistake spread like wildfire throughout social media and throughout, Twitter and those kinds of things, those kinds of platforms. And so, the problem is sometimes then the damage is done. Even when the correction comes out and says, no, this wasn't true at all. It's like the damage has been done. And so I think that's unfortunate. I think people and your listeners and your viewers need to be cautious about everything that they read, to be honest with you, because you got to think about what's the motivation, why does somebody want to put that out there?
I get that. And I wonder if what you think about the potential side effects. Have we learned anything about the side effects or the long-term effects, I should say, of the actual COVID-19?
Oh yeah, that's a really great point. And I get the debate on both sides. Somebody says, well, we don't know the long-term effects of this vaccine. First of all, you need to recognize vaccines don't typically historically provide long-term effects. They're it's kind of a one and done kind of thing. It provides you that immune response. You get antibodies that your body creates. Your body makes the antibodies, and then they hang out in your body. So the vaccine itself, that's out of your system within 30 days or so, or less. And so, but the infection, the COVID virus, if you get infected with the COVID virus, we are seeing more and more the long-term effects of actually getting COVID. And unfortunately, it's not great news. And so we are now anticipating on the healthcare side, a long population, a long period with a large population of individuals who have signs and symptoms that just kind of linger from COVID for many years, to be honest with you. And we're still early. I mean, I know it sounds like that. We're still early in the research to see what this looks like. But right now, just some data, the fatigue seems to persist. We have individuals that have had COVID 6 to 8 months ago that still do not have a return of taste or smell. We have individuals that still show damage on their lung scans. Some of that damage, about 20% of the time, is permanent lung damage or fibrotic damage to the lungs. And these are individuals with mild symptoms. And it may be that you don't really recognize it. Maybe you just notice you get a little winded more when you walk upstairs or when you're walking across the parking lot. It could be mild. Now, how much of that actually persists, it's too early to tell. Our hope is that it will continue to you'll see improvement and that it won't be permanent. Latest study came out and said a third of individuals that have been infected with COVID, either mild or moderate, had some sort of psychiatric or mental cognitive impairment, in terms of like the brain fog, or they were at higher risk of a certain mental disorder. So that's concerning. This is all, again, and I know I keep saying this, I've actually said this to you and I've said it to different groups, that this is still the tip of the iceberg in terms of that research. It'll take us probably a year or more, or maybe even several years, to really see what the after effects are. We're seeing almost like chronic fatigue syndrome or fibromyalgia type symptoms with individuals that have recovered from COVID. We're amassing large databases of individuals who have had COVID and have gotten over it and still have some lingering symptoms. The highest risk to have lingering symptoms seem to be individuals that were hospitalized, females, mid 40s or so. That just kind of seems to be, when you start trying to correlate the data, that kind of seems to be one of the underlying things. But it really can happen to anybody, in all ages. We've got teenagers and those in their 20s that still are having issues with COVID long after their infection. So certainly not seeing anything like that from the vaccine standpoint, because that's, that it's just a whole different mechanism. The vaccine is not the virus. It's just a little piece of the protein that we're basically teaching the body to respond to. So hope that's helpful.
It is helpful, and I think it's concerning. What do you feel like these variants that aren't here will eventually get here and spread? Is that a given?
Yes and no. I think certainly so here in the state of Arkansas and even in Northeast Arkansas, we already know the UK variants here. We feel pretty sure that at some point we'll see the South African variant. We already know the Brazilian variant is in Arkansas. We're seeing a large amount of the California variant, and that spread pretty quickly from the West Coast, obviously from California. We'll see other variants, I'm sure. The big thing or the big question that everybody has on their mind is, well, how well does the vaccine protect? And so I think we're seeing, and we're still looking at that data, but right now we feel good about the vaccine and the protection that really the Moderna and the Pfizer, for sure, those vaccines provide a large amount of protection. Those are just, the technology is amazing. When I get people asking me about that, they say, well, weren't these rushed vaccines? And what you need to understand is we started studying this technology in 1991. In the early 1990s is when we started studying this technology. And we were doing it. We were doing animal studies and everything, even back then, on this kind of technology. And so this was a natural step for us. And what happens is sometimes when there is a natural disaster or a global disaster like this, it does force us, to move forward. Maybe even at a little quicker pace than we would have, but there was nothing from the technology side that was hampered there or that was rushed. I think what people understand is the bureaucracy or the red tape that occurs in our own federal and state government. I think that was a little better, as opposed to, hey, yeah, we'll look at your vaccine sometime next year. We'll look at your vaccine next week. So the data, it didn't do anything in terms of changing the data and the rigor that had to occur in the trials. And so I hope people can understand that. The other piece is, don't be surprised if this technology continues to be used in other vaccines. When you think about the flu vaccine, you know how long we've been using that? 70,
all my life.
Yeah, 70 years, that same technology.
Is that
We've
right?
been using that technology since 1951. Tell me what you're using in your house, in your office, anywhere that you're using the same thing you were using back in 1951 that you use now. I mean, it's almost embarrassing. Yeah, exactly.
That's the only thing I can think of.
I bet even that's a different composition. But I mean, we've probably got a different way to fire our ceramics, or so to speak, now. But it's almost embarrassing, the fact that we were using, we're supposed to be medically advanced, and that we have all these answers, and we're the best country in the world in terms of our medical technology, and we're using the same technology we did back in 1951. And that was one of the problems with the flu vaccine, was that we couldn't pivot. If we did a bad match, if we guessed wrong on the flu vaccine, that's why you had bad flu years, is because, we have to guess back in the early spring of what the strain that's going to be circulating in the fall is. If we guess wrong, because it takes 6 months to grow it on eggs. So if we miss that, you can't turn around and make a new flu vaccine and hurriedly get it out so that people can be protected. You just got to suck it up and go through a bad flu year. This kind of technology allows us to pivot quickly, make adjustments to the virus that's wreaking havoc on our population, and really it's going to provide for a healthier outcome.
And you made me think of something. I don't want to take more of your time necessarily, but I do want to ask, do you feel like we've seen fewer flu cases because people are wearing masks?
Yeah, and let me be clear. Yeah, no, absolutely. Let me be clear about that too, because I've heard that too. As well, how do you know that you're not calling that we're just calling these flu cases COVID now? Well, it's the same way that we know the difference between strep throat and mono. Both of those cause a sore throat. Well, how do you know the difference? Well, we test for them. We test for mono, we test for strep, and you can go to your doctor's office today and get a test for one of those. And so, there obviously are some physical exam differences that a physician can pick up on, but generally speaking, we just test for them. Same thing happens with this. We can test for COVID, we can test for influenza. They're looking for two different viruses. We are pretty good at being able to discern that. Now, yeah, we absolutely saw low flu numbers. We saw low flu numbers here in the state and across the country. And you're right. It's because of the mask wearing, the social distancing, the hand washing. People may not realize this. The molecular size of the flu It's almost the exact same size as COVID-19, about 0.1 micrometers. And so they basically were the same thing. So if you're doing one, if you're protecting yourself from one, you're protecting yourself from the other. So flu never had a chance to get a hold of people in the fall. Typically flu season starts September, October. We've had some later flu seasons actually in the past few years, but usually that's when it gets here, it starts circulating, starts infecting people because you're all, everybody's out shopping at the restaurants, blah, blah, blah. And that's how the flu passes around, just like COVID. It's a respiratory virus. It never had a chance to get here and take hold. So that's why we saw very low to no flu numbers. However, we're starting to see more now. And so that's not a surprise either. As we start to remove masks, we start to congregate together, start to get back some normalcy, don't be surprised if you start hearing about some flu cases going up. That would not be a surprise at all.
Well, I think you've answered a lot of our questions. And, I want to take the time to say thank you to you, your staff, your team, all the doctors and nurses who have dealt with this over the past year and a half going and continue going. There may not be an end in sight, and you're still put together and you still kept it together. And I think our community owes you an incredible debt of gratitude. And I know you're humble and I know you are doing all kinds of things in your personal life to maintain the determination that it takes to get this done. And we thank you. Well, and Mayor Copenhagen thanks you seriously. So.
No, I appreciate that. I can say nothing but great things about the city and how well you guys have been supportive. I mean, this has been a difficult time for everybody, in every different, aspect of the business world, small business owners, and just everybody has really struggled through this. And, not having the immediate answers is frustrating as well. We were frustrated on the medical side from that. My colleagues that are on the front lines there in the intensive care units at the hospitals, hospital administrators. I mean, certainly in the healthcare community, we had a lot of people that were affected deeply by this. I mean, this was a life-changing for many of them. And so I think it's kind of what you sign up for. And I think people recognize that, certainly in the healthcare side. I know you yourself, obviously in leadership, this is just part of what you sign up for. And so I thank you for everything that you guys have done. And there is a light at the end of the tunnel. I always want to be careful and make sure that I'm putting out the information that I know to be true and accurate based on the data that I have and the data I have access to. We're in a much better place. This summer will be a completely different summer than even last summer. And again, a lot of that is just due to vaccination. So for individuals, you need to get vaccinated. If you haven't been vaccinated, that is your key and our key out of this. That is how we as a collective, we as a community move past this, is with our vaccination numbers. And it's not just for those that require 2 vaccines. It's not just one of them. Here in the state of Arkansas, we've had about 14% of the people are not going back and getting that second vaccine. So that's a big deal. You got to get both. If you're getting the Johnson & Johnson, that's just a one dose, but Moderna and Pfizer are 2 doses. So don't, and that's what bumps you up to the level to cover you from these variants. And so I think you're going to see vaccines come out for kids this summer. I think that's going to be great. So I truly believe we're in a much better place this summer. I think we'll be in a much better place this fall. It may be a little rocky at times in the fall, but it's not going to be, from what I can tell, anything like what we had last year.
Very nice. Very nice. He's Dr. Shane Speights. He is the Dean of the New York Institute of Technology, College of Osteopathic Medicine at Arkansas State University. And if that title's not long enough, he's also a medical director for the city of Jonesboro. And thank you for taking the time to visit with us, Dr. Speights.
Absolutely, Bill. My pleasure. Thank you.